So you know that I'm early in my career. Uh, this is year 3 now, and I wanted to kind of pick your brain a little bit about what do you think you would do differently if you had to do those early career years again, or is there advice that you would give for an early career surgeon?
That was a long time ago. And I mean, well, actually, I was an art history major who was planning on, I was going to be a plastic surgeon.
Right.
I mean, the short answer is I'm probably not the best one to give advice to the up and coming young person, but I will say that, yeah, I was introduced to plastic surgery at a time when it was before free flaps. It was remarkably a creative period where it was really the understanding of kind of the vascular anatomy, but just the creativity of the surgeon could define what the things you could do. And I really wanted to apply that to extremity reconstruction. And when I saw I could do that via an orthopedic residency, I said, "Oh, that's going to be great." And I ran down that path, did my orthopedics, did a year of plastics, and then by that time, free flaps were in, and it was really just becoming a much more less interesting idea. And I transitioned into orthopedic trauma. I never really did an orthopedic trauma fellowship. So the lesson, I mean, what I would say was, don't be afraid to change. I mean, I'd just gotten married, and about 2 months later, I realized my entire career path had to change.
Right.
And I basically, fortunately, put up a help wanted sign, and Gary Friedlander at Yale offered me a job. Back those days, it was a handshake. And, I worked hard, and I was, just by luck, I fell into quality people in an interesting environment, made an embarrassing small, I mean, the residents now make more than I made the first 3 years, for sure. But anyway, so advice is, go with your heart, but keep, don't put blinders on. I kind of had blinders, and I wish I'd known more about scientific method and engineering. It would have helped a little in my research. But on the other hand, being a little ignorant and inquisitive allowed you to think in ways that were different than your attendings did. And I didn't have a fellowship guy that, I just going to do exactly what he did. And so, I looked at intertrocks differently than other people, and, kind of it worked out. So in terms of, the advice to young people is surround yourself by quality people, and realize you can move. I mean, it's, your first 3 years, you'll never get back. So, do what will make you a better surgeon.
And you touched on this a little bit, which is interesting, but we're all kind of a product of our experiences, right? And so I can kind of distinctly remember talking to you about the joint jack. One of the first times we did a plateau and the importance of using the femoral distractor. Can you talk a little about people that influenced you in that way, or a story?
When you say joint jack, you mean the distractor?
The distractor, yeah.
Well, I mean, that's a story in and of itself. It probably is the reason I'm an orthopedic traumatologist. I was a third year. I only did 3 years of ortho, so I was in my middle of my orthopedic career at San Francisco General, and I witnessed some remarkably underwhelming ORIFs of lateral plateau fractures done by attendings that, I wanted to respect, but it was just kind of a flail. And then they were saying, "Oh, that looks pretty good," and I was disappointed. And rummaging around in the ortho room, I came across a never used in the box femoral distractor. And I looked at it, and at the time, the only thing we were doing on the spine would be Harrington distraction compression rods, and the original Harrington system had something that looked very much like the distractor. And I looked at it,
Okay.
and then I went to the AO manual, and it showed the distractor, and it showed how it worked. And this light went on, and as you probably, the term you use, joint jack, because I'd always ask residents, when they'd ask me, why do you use this? And I said, well, have you ever changed the tire on a car? And back then, residents actually did change the tire. Now I say, how do you fix a flat tire? They say they call AAA. But they'd say, well, you park it and you set the brake and you jack it up. And I say, well, why do you use a jack? They'd look at me like I was crazy and say, well, of course you would. I mean, I said, well, you guys are strong. You can just hold the car up and just do it quickly. And they'd say, well, that's ridiculous. That's what the jack's for. And I'd say, exactly. That's my point. That's why I use the distractor. And so, I mean, and then also, that was like 86. And, I didn't do AO basic until 88. And that was right when, Jeff Mast published his planning and reduction techniques, and that was actually Tom Fischler gave me this copy right here.
Oh, beautiful.
But I mean, all over it, the distractor was everywhere, and he
Right.
would describe indirect reduction using that tool. And I went in, and I had a good fellow who allowed me to do some stuff, and we used the distractor on a plateau, and it was a game changer. And so, I mean, and it kind of gets back to what you talked about before, is no one used it, and it just made sense, and it did everything that Mast would stress, is this idea of a very efficient, stable, sequential way to go from instability and malreduced to stability and reduced as just a very clear path, rather than a hopeful, just pull hard and have the resident pull hard, and I'll try to stuff the graft in and get a clamp on it.
Right.
That was fun. That was exciting. I got carried away. I hope that answered the question.
No, it did. It did, for sure. I guess along the same lines, there's been so many advances that I can think of that I've seen since I was a resident. What do you think was the biggest advance that's come about in orthopedic trauma in your career, or what had the biggest impact?
I'd probably say, or actually, definitely, the trauma block. I mean, scheduled time. Like as you heard, back in the day, I had pretty much, I'd say, guaranteed 7 or 8 o'clock start times at night. I mean, if you didn't book a case within 72 hours, your room was given away. And so the idea of holding a room for an injury that wasn't in the hospital didn't exist at my institution. And once, I mean, the hospital saw that they could make money by actually making a trauma room, but that opened up, we were now did respected things rather than the guy who's just doing stuff at night. And that just, the dominoes fell to you get better teams, you'd be around in the hospital when the hospitalists when the staff was working, you'd get respect, you'd be able to communicate with things, and you'd recruit. I mean, people like you now could have a lifestyle,
right,
be, so yeah, I mean, I would say, yeah, there's always a new whistle and bell, but that change in the way trauma was approached, I think it's probably helped patients more than anything, and certainly allowed good surgeons to do that. I mean, in terms of like implants, I'm a little biased probably, but I'd say intramedullary hip screw was interesting because I just came on when that was the gamma had just, everyone thought it was great, and then when the results started coming in showing it was, it was horrible. It's with all these complications, but I really was impressed with the fact that and it was never written about or published really until I kind of started hyping it, but it's an intramedullary buttress and it really resisted excessive collapse. And it just, no one was using a TSP or anything, but and the data is still out the way outcomes are measured, but it's unquestionably, it was a shift. Yeah. And it allowed you to achieve stability in a much more biologically friendly fashion. From an implant, actually, I mean, you mentioned you wanted to ask this question. I really thought about it, and I would say, I mean, locking plates for certain metaphyseal fractures are great, but what we didn't have when I started, we didn't have plates that varied their screw density and their screw size. And so many complex fractures, I mean, you'd see these elbows Jesse Jupiter would repair, and he'd have like 5 different plates, but you could never put strong stuff up where the bending forces are and get multiple screws down where you just had small pieces to work with. And the creation of these modified plates, and particularly the ability of different sizes, I think was great. I'm currently, must admit, I'm not a big fan of the variable angles. I think that's I mean, with the periprosthetic or something, maybe, but it's more marketing than anything.
Right.
The ability to know the angle of your implant, your fixed angle device. If you look at the blade plate and you look at what Mass taught, is that allows you to drive your reduction with the plate, knowing that relationship. And once you have a variable option, you lose that. So those would be the things I think have changed. But you are a I'm sure you have block time.
I do.
You can thank old folks like me for that.
Yeah, I'm super thankful for it. We have a trauma room every day of the week, so
we're going to be 3 trauma rooms at least some days now, starting in another month, I guess.
I know. See, I know the faculty is growing, so that's a good thing.
Well, I'm going to do my best to kind of slow down that.
I think one of the more important things that we deal with, at least early on, and try to decide how we are going to deal with in the future is failure, right? Failure is a real thing, and we're all going to come up against it. What would be your advice, to me or to young surgeons about how to deal with failures?
Well, you're right. I mean, we all fail. I guess I'd look at it differently, and if you're only cogitating and reflecting on cases that went poorly, and of course those you can't help but do that, but you're missing the boat. Me, we need to look at every case we do, every case. I mean, on the drive home, whenever, there needs to be a time when you reflect, and you should till I look in my mirror, I say that I should reflect on the things that went well. I mean, just take the time to think, what went well about that? You know, what, and why did it go well? And then, you know, after you've listed what's gone well in a case, think, well, you know, what didn't go so great? What could you do differently, and why didn't it go well?
Mhm.
And so if, you know, if you're only stopping to think about a case that went sour, you're not going to, that's not a very exciting thing to do. But if you have a great case and you actually spend some time like, why did that go great? Was it preparation? Was it, you know, the Lord was maneuvering my hands like, you know, I was like God in the oar and it just fell together? Or, you know, if you know, the AO, you will, if you haven't yet, you know, they have these faculty education programs, and you know, your competence is based on three things. It's knowledge, skills, and attitude. And any activity we do, you really can separate them into those three domains. And when you do well, you probably, you know, you probably engaged all of those effectively. And when you don't, when you don't do so well, if you reflect, chances are it's going to be, you know, you didn't plan it well enough, and your knowledge going in wasn't quite right, or you know, you just technically couldn't quite maneuver for whatever. Or most importantly, it's when you realize, you know, your attitude, you didn't take the time to prepare, or you didn't really take the time to understand the patient well enough to know that might not have been the right operation. But if, again, the point would be reflect on the good things, because it's, then it will stick. And we all remember, you know, I can remember 2 days ago, I just did a really dumb thing. It was an attitude thing too. I kind of was nasty to the staff, and yeah, you hate thinking about that. Anyway, so if you reflect on your successes, I think you'll be able to manage your failures very effectively.
Yeah, thank you for that. That's actually helpful, because I take the failures to heart, of course, and perseverate on them.
I will never forget the first perineal nerve that I still don't think I transected it, but I never saw it. I mean, and it was a young person, and
Yeah.
For the whole weekend, my wife wouldn't even talk to me, because I just, you know, you just couldn't. But so then you start hitting some good ones, and you realize you're more prepared, and you're, you know, anyway. So everybody's been there.
Yeah. One of my favorite things that we did in residency was long-term follow-up, which to my knowledge is your baby. And so
why?
Why did I like it?
You know, that's, well, you know, just the whole conferences have been pretty much destroyed by, you know, Zooming and time. But I'm glad you bring that up. But what was it that you liked about them?
Well, I enjoyed long-term follow-up because it was an opportunity to see like the full breadth and depth of the patient's experience. And, you know, as a resident, you're rotating, right? Every couple months. I remember doing surgeries on patients and not really having the ability to see it through most of the time. And so it was nice to say, oh, you know, this is such and such, and we met them here. This is where we met them. Maybe you did their consult in the ED. Maybe you saw them, maybe put their splint on, you know, Dr. B fixed them. And this is what was really going on at home. You know, this is what was going on at home when he got hurt, or he was supposed to get married the next week, or, you know, his childcare was disrupted, and and this is how they figured it out. And this everything came together at the end. I felt like we get, you know, caught up sometimes in the x-rays and critiquing the reductions, and maybe don't see, you know, the forest as clearly as we should. You know, the details are important about, you know, the patient and how they're going to cope with the the overall trauma disease, not just the ankle fracture, or the pilon, or the plateau. So that's why I liked it. It was fun. So
Well, I'm flattered. Thank you. Yeah, just for anyone, 4 people that might end up listening to this.
the seven.
Yeah, but no. So we, like most places, we had a weekly conference that reviews all the cases that were done, and the residents would present them, and the attending might comment. But the bottom line is the final X-ray of this great case would still have the staples on, and the patient probably hadn't even been discharged from the hospital.
Right.
It's a really great case. And I when Shasta was there, I'd already had patients of 10, 15, 20 years follow-up. And as I think I probably said then, it's nothing spoils good results like follow-up. And so I just really wanted to get a reality check on, just because it seems like it's a lot of hardware and everything went great, it's not necessarily a good result. So I would have the resident who did clinic with me, they would present a case every week of someone with at least a year follow-up. And it just gave the rest of the team an ability to just describe very nicely what Shasta had explained. And I mean, it is fun to see. I mean, and the residents don't get to follow the patients through. The reason I did it though was just to make certain that people realize it's not over just when you discharge the patient, not without a complication. And it's only when you see how they really turn out, and as Shasta mentioned, how you understand their role in the difference between an unemployed, poorly educated person and a white collar person who's got resources. You have to build that into your plan. I mean, you don't have to, but your results will suffer. So but it's exciting that I wish we did that now, but we, at least not since the COVID bit, if we really had that opportunity. I'm hoping it'll change next year.
Yeah, I'm hoping everything should be back to normal eventually.
But yeah, just the eventually is that eventually might be past my timeline, but we'll see. Anyway.
Yeah. So let's say that we're having this conversation 20 years from now.
15. Let's see.
Okay, 15 years from now. 15 years from now.
My mother is 97, and yeah, that would put me nearing 90. I don't know. Anyway, go ahead.
Yeah. So we're 15 years from now, and you are emeritus professor talking at Yale about the landscape of trauma over your career, and where you see it heading. What are you going to be discussing? What are your thoughts?
Well, I want this to be upbeat.
Yeah. Keep it upbeat, please.
I hope. I mean, I'm concerned with the erosion of the concept of being a medical doctor. I'm sure you're a personable, humanistic person, and it is really fun. It's a responsibility, but it is fun to improve the quality of someone's life and to experience that. And yet that will, getting that full experience will mildly decrease your productivity. You will spend an extra 2 or 3 minutes with patients learning about what happened at home, reminding them of it. But that's what makes it fun. And now we're not even called doctors. We're called, we're providers, and we're proceduralists.
Mhm.
And yes, if you want to be a left elbow ligament reconstructor and publish, great. But 15 years from now, I hope that people would be hearing this and say, well, that's crazy. No, we're doctors, and we take patients, and yes, we do surgery, and but certainly I'm not going to say the best thing, but because the best thing probably is spreading what you've learned as far as you can through residence or through writing. But don't minimize how much fun it is to be a doctor, in addition to being an excellent proceduralist. And because robots and everything else, fixing fractures with robots, I think, is farther down the road than many things, but it's coming.
Yeah.
But, anyway, so that's what I would hope. I hope we still have people who view taking care of patients as more than punching the clock and trying to schlep most of that off to someone who's less, got less years of education.
Understood. One of the things I think I took away from you is soft tissue management. And I remember you speaking to us about that, every case, and making sure that we were particularly respecting the biology. Talk to me a little bit about where that came from. I'm sure some of your experiences of plastics informed that, but.
Yeah, well, I think it's interesting, and I probably harp about that now more than I did even when you were there. But we learned. I learned the vascular anatomy of the soft tissues, and I don't think, and I try to stress it at Yale, but I don't. And we spent my training. We did 2 years of general surgery before doing any orthopedics.
Right.
And we, so anyway, so basically, I think there is probably an inadequate knowledge of where, we talk about the skin, closure, and you talk about the skin. But there's parts of the skin that hold suture, and there's parts of the skin that hold plexi, that keeps things alive. And none of us would ever put a screw into well, I got a great bite of muscle, I'm going to incorporate the screw in that. But many of us throw sutures that way, where we're really, it's an inefficient and relatively biologically insulting. And everyone says, fracture is simply a soft tissue injury with a broken bone. But it's really true. And well, I take that back. It's not true above the equator of the patella. You can pretty much do anything and you're going to get away with it. But if you're dealing, with below the patella, your wounds need all the help they can get. And we teach anatomy everywhere else. We ought to teach and practice anatomy with our soft tissue. It's certainly, I'm at best in, an average manipulating the bones. But I know I've minimized my complications by getting that. If you can't get control of your envelope, you can't rehab. You can't do functional motion. You can't. You have to immobilize till you have a sealed envelope, and you should be able to do that very quickly if you respect and understand how to apply force and closure to soft tissue. I hope you're doing that. I'm sure you are.
I am. I'm never squeezing the skin with my Adsons. I can remember using a dental pick instead of the Adsons occasionally to suture. So
I still do that. Yeah. It's just, yeah. Guilty as charged.
Yeah. No, it's there. It's whatever. So it's good news though, because what you're doing is impactful and poignant. So yeah, I remember it. So.
Well, Chester, you're right. It is. I mean, remembering the distractor. It's been fun. 3 things that you brought up today that I'll remember. Makes it interesting. So
yeah.
All right. Have a great weekend, and
You too.
thanks for doing this. And we'll see how it goes.
All right, sir.
Take care.
Bye.
Bye bye.